Hello, everyone. Welcome. Thank you for joining today's webinar, Nurturing Dignity, Understanding Hospice and End-of-Life Support, presented by Home Instead and hosted by the American Society on Aging. We'll begin shortly, but before we do, let's go over a few important notes. You can apply for your certificate immediately after today's webinar by using the tab above the presentation screen. Be sure to click on Add Membership to select your certificate type or accreditation board you need. If you don't have a license number, simply enter NA. You can also opt for a certificate of attendance. Please note that if you skip this step, no certificate will be generated. Throughout today's session, there will be checkpoints to ensure active participation, so please make sure your pop-up blocker is disabled and be ready to respond when prompted. Make sure you're logged in with the email address you registered with. This allows us to track your attendance. You must stay logged in and complete the checkpoints to be eligible for your certificate. Presentation slides are available now in the Materials tab and can also be accessed later in your classroom. The on-demand recording for this webinar will be available in your classroom within 48 hours. For more information, check out our webinars page for helpful guides and FAQs, which can also be found in the Announcements tab in your classroom. If you have any technical issues, the Help tab at the top of your screen will connect you to support. If you have any questions during the webinar, please submit them through the Q&A tab below. We'll do our best to address them in the last few minutes of the session. And now I'm excited to welcome Dr. Lakeland Eichenberger, a gerontologist and caregiving advocate with Home Instead, where she educates communities on aging challenges and resources. Joining her is Jules Stracadamno. I think I pronounced that correctly. I'm so sorry if I butchered that, Jules. A registered nurse with over 12 years of experience in palliative care, critical care, and LGBT plus health at Honor Home Instead. Jules focuses on innovative solutions to help older adults age in place with dignity and independence. Together, they bring a wealth of expertise in the fields of aging and caregiving. Thank you so much for being here today.
Thank you so much, Victoria. Hi, everyone. So glad that you are joining Jules and I today. We are going to cover a really important topic, end of life, and it's not one that's always easy to talk about, so we're really glad that you're here. Hopefully we can make this conversation a little more approachable, give you some tools, ways of talking about it, and some information that will help you have these conversations, because we know that they are so important. While we might not want to talk about end of life, we know that if we don't talk about it, then when that time comes, we might not be carrying out the person's wishes. We might be stressed over, what would they have wanted? So if we're able to have these conversations early and understand the options for care, then again, we can carry out those wishes and have a better overall end of life experience. So I'm so excited to be joined by Jules today. Jules, hello, welcome. Jules has a wealth of experience, has worked in the field of hospice for a number of years, and now we get the pleasure of working together at Honor and Home Instead on a number of initiatives. So you'll hear from Jules in just a bit. But really quickly, our objectives for today, we're going to talk about end-of-life wishes and how that can help preserve dignity. We'll talk about the realities of hospice care and utilization of this type of service. We'll also talk about the benefits of hospice and palliative care. I think there's a lot of myths and misconceptions out there that we hope to debunk. And then we'll talk about some resources and support for families at end of life. And to get us started, I have this quote slash question. It actually was posed by Ira Byock. He is a palliative care physician and end-of-life advocate. He's very well known in this space. He has written books on the topic. But for the purpose of today, let's consider today was our last day or the last day of our loved one's life. How would it be different from all other days? That's an important question to think about. Many of us would probably spend our last days whether it's our own or our loved ones, nurturing as much dignity and respect as possible. We want to carry out that person's wishes to the best of our abilities. And so if we were to kind of live like that today, then hopefully it would spark some of these conversations. I think there's a country music song that's like, "Live Like We Were Dying." It's a catchy tune, but we need to talk about end of life wishes, because we just never know when our end days will come. And especially in the work we do with aging adults, often we are caring for them through end of life. And so we want to be sure that we're knowing their wishes and encouraging the conversation amongst their family unit, so that family members understand their wishes, and also so we can reduce the number of if only moments after the person passes away. Because if you think about it, if you weren't able to have those conversations, or you didn't know what the person wanted, then after their passing, you might be left with a lot of kind of those what if, or if only I did this kind of questions. And we hope to avoid that to the best of our abilities. But I think this is a challenge, because in our culture, at least here in America, talking about death and dying is still taboo. It's hard. And at Home Instead, a few years back, we did a survey around end of life, and people reported back to us that they're more comfortable planning for their funeral than the years leading up to it. And planning ahead for your funeral, of course, is important. It can help your loved ones know and understand your wishes for burial and memorial service and that sort of a thing. But at the same time, those years leading up to a person's passing is just important to plan for. But sometimes it can be really hard to come to terms with. We don't like to admit the fact that we are mortal, that our lives will come to an end. So much of our culture is trying to kind of reverse the aging process, to really kind of glorify youth. But the reality is, at this point, there's no cure for death. There's a 100% death rate in the United States. And so our time will come. And so planning ahead for those years leading up to our death are really, really important. But again, it can be hard to have these conversations, but you do have to have them in order to know the person's end of life wishes. And so some just data around the discussion around end of life. I think the good news is people think and feel that it's important to talk about end of life. So they feel like it's important, but only a small percentage of them are actually taking the time to do so. Just under a third of people really have had the important conversations that they need to have with their loved ones and the important people in their lives. Also, people feel like it's important to express these wishes to their healthcare provider, but again, very few people have actually done so, had the conversation with their physician, or passed along their advanced directives to have as part of their healthcare file. So again, I think as professionals working in this field, we have an opportunity with the aging adults that we work with, and the families and the caregivers, to spur these conversations, to ask, do you have an advanced directive? Have you talked about your end of life wishes? And if not, can we supply them with some resources to help families have these really important conversations? And again, it's important to talk about what happens before death and what happens after death. And so kind of knowing the difference, that there's important discussions that need to be had kind of for both before a person passes away, in terms of their advanced care planning. What are the legal documents that they can put in place, like an advanced directive to express their wishes leading up to death. And then, of course, that end of life planning, having those advanced directives, but then also after you pass away, have you expressed your wishes for things like organ donation? Have you put together your wills? Have you got those funeral plans put in place? I know, many people prepay for their funeral, but again, they haven't had conversations about things like end of life care, hospice, those sorts of things. And so when you are having those kind of advanced care planning discussions, it's important to document them in a legal document. And then that document will take effect when you become incapacitated. And again, when you are incapacitated, that means that you are unable to make your own decisions because of your physical state. And so if you are able to put these plans in place, you can express your wishes for things around, would you want CPR to be administered? Would you want to be placed on a ventilator in emergency situations? Would you want to have artificial hydration and nutrition? And if you don't want those things, you can opt for something that's called, often referred to as comfort care, palliative care, hospice care. And sometimes what happens is when a person does not make these wishes known, even though they might have those wishes and desires, if they don't make them known, then often the healthcare system, they're trained to take life-saving measures. So that's why it's really, really important to have these conversations about the type of care that you would or would not like to receive at end of life. And not only the types of services, but also talk through where you would like end of life to take place. It's something important to think about. Many people want to die at home, but not everyone does so. Most people die not at home, so in a hospital or other setting. And so it is important to think about. And some people, so the reverse of that, they don't want to die at home. They don't want to pass away in the home because maybe they feel that their loved ones who will still be living in that place would not feel comfortable being there after their passing in the home. So again, these are important things to talk about. And no one will know your wishes unless you have the discussion or you document them. But as I mentioned earlier, not everyone is taking this next step of actually putting their plan on paper and creating advanced directives. Actually, only a third of Americans have an advanced directives, which means 2/3 do not. And so if we all on this call were to reflect, have we taken the time to create our advanced directives? I remember I was in death, dying, and grieving class in my graduate studies, and one of our assignments was to plan our own funeral and to document our end-of-life wishes, to create an advanced directive. So I did that a number of years ago, and then we just welcomed our first child into our family. And so my husband and I thought, wow, we probably need to actually put a will in place and update our advanced directives because now we have a tiny human to care for. And so I actually recently just did this. And it can be emotional to have that conversation with your family and loved ones, but also it can provide such peace of mind because now in my situation, my husband and I are on the same page. We have these things documented. We both know where they live in our house. We also have a digital copy. And so I know for me, my next step is I need to share them with my healthcare provider. But kind of maybe do just a little self-check and inventory right now as to where you are at in kind of your own end of life discussions. And sometimes, if it's within a family unit, sometimes the younger members of the family talking about their wishes can open the door for conversation for the aging members of their family to also openly talk about their wants and wishes. And as I mentioned, there's such a negative stigma sometimes around end of life and death and dying that I thought it was important to highlight the positives of planning for end of life. So the research has found that people who engage in end of life planning, they're more likely to prefer services like hospice and comfort care over hospitalization at time of death. And we're going to talk more about those services in just a bit. And also, those who have done end-of-life planning are more likely to focus on less expensive forms of care than those that do not have advanced planning. And so what that kind of means is especially as a person gets older, maybe they don't want as many of those life-saving measures. But if they've not expressed it, as I mentioned earlier, the healthcare system might default to taking those life-saving measures, which might result in more expensive care. And And also the quality of life for that person might not be, what they would have wanted. And so if they do have those plans in place, they're able to, express those wishes. And often the kind of the expense side of their care at end of life is lower. So again, I think the takeaway is it's important to have these conversations for so many reasons, to make sure that we're honoring the dignity of the individual, honoring their wishes, that we're providing peace of mind for the family and those providing care to that individual, because they know, okay, my loved one would or would not want this type of care. And then also it can result in a better death or better end of life experience. So I think that those are important things to consider if somebody is hesitant to have these conversations. So when we talk about the options for end of life care, we're going to go into all of this in more detail, but you've heard me mention palliative care and hospice care. Those are the two kind of main medical options for care towards end of life. But also family caregivers often take an active role in end of life care, which we'll talk a little bit more about. And because of that, there's often respite and home care that come in to support families at end of life and through that transition. So before we dive too deep into this, I thought it would be kind of fun for Jules and I to address some of the myths around end of life care, because Jules, I know you've worked in this field for a long time, and I'm sure you've come across many of these misconceptions like I have. So I'll put them up on the screen and then we can kind of walk through them one by one. That sounds okay to you? Okay, so the first myth that I come across is that hospice is a place. Jules, have you heard this one as well?
Oh, yes. And actually, before I even worked in this field, I believed this to be true as well. So I've heard this many times.
Yes. But what we know it to be true is that hospice can really take place wherever the need exists. And it's often in somebody's home. And so I think a lot of times people think, oh, my loved one needs hospice. They need to go to a hospice house. I mean, we have one of those in my community. It's called the hospice house. And so people automatically think that's the only place hospice can exist and take place, but it's not true. And so Jules, in your experience, would you say the majority of patients that you saw were in the home?
Yeah, majority of them are in the home receiving receiving routine home care. If someone is in an hospice facility or house, like you're calling it, that is usually something called general inpatient care, which can also happen in a hospital. But usually those places are utilized when someone has symptoms that are not easily managed. So if symptoms can't be managed at home, that's when an inpatient setting is more appropriate. But usually folks are in their own home or in a setting that would be their own home, like a memory care unit or an assisted living place.
I think that's a very helpful call out, that if the needs are higher, then it's more likely that person might need care outside the home. But
yes,
often the hospice can be brought into the home. And I think the terminology around like hospice, palliative care, comfort care, there's some confusion around it. I think sometimes, especially when a well-known individual in society, like a former president or celebrity, talks about end-of-life care, you often hear comfort care. We don't always hear it called hospice or palliative care. And sometimes there's some misconception that it's one and the same. But that's not exactly true. So we'll put the slide up here. So they both have the same principles of comfort and support, but palliative care can begin at diagnosis and continue through treatment and beyond, where hospice care is really designated for somebody towards the end of life. So Jules, do you have a even more clear way of explaining that, or how would you explain the difference if somebody was asking?
The way that I remember it is, and what I compare it to is the saying of, not all whiskeys are bourbons, but all bourbons are whiskeys. In the same way that all hospice is always palliative care, but palliative care is not always hospice. So the thing to remember here is that palliative care is really something used to help treat symptoms. And that could be if someone is on a journey of trying to cure their disease, or if someone is on a journey to choose hospice and plan for end of life. Palliative is really meant for symptom relief. That's how we think about it in the medical setting.
I like that analogy. I'm going to remember that and use it. I'll give you credit. But that's a really good analogy. So not all palliative care is hospice, but hospice is always palliative care. So,
correct.
But I think that the great thing is that the goals of both are comfort and support, and pain management, symptom management, pain management. So that's great to know. Okay, so the next myth that I sometimes hear is hospice care is expensive. And actually, most people who utilize hospice services are over the age of 65. And so if they qualify for Medicare, there is a Medicare hospice benefit. So that is good news, because we know the cost of care is definitely a concern for many families, many aging adults. And so if an individual is over the age of 65, it's likely covered by Medicare. But if you're not age 65, often various insurance carriers will cover hospice and even palliative care in a number of circumstances. So anything to add to that myth, Jules?
Yeah, I would just say that I think that we are all sort of programmed to believe that medical care in any setting is going to be expensive. That's just kind of what we're programmed to believe. So that's probably why folks think this is true. But I have gone to so many homes on an admission. I was an admission nurse for hospice, and also I was a clinical liaison educator. So I would oftentimes, go to someone's home and meet with the patient and the whole family. And when I told them that we could get them all of their durable medical equipment at no cost, some people's jaws just dropped. They couldn't believe it. They couldn't believe that we could get a hospital bed. We could get, oxygen in their home. All of these different things at no cost to them because of this Medicare benefit was huge, because they didn't know it was something they could access. And, if someone needed some of that equipment prior to this, they would have to pay for it. So it's a really big deal. The medical equipment aspect of it is a big money saver that people don't realize they have access to.
Yeah. And I think that is one of the many benefits of hospice is it is a really holistic service, which I know you're going to dive into more in just a bit, but it really cares for the whole person. And so things like those medical devices, durable medical equipment that they need, it's part of that holistic care. And so as a result, is part of hospice care. So thanks for sharing and expanding upon that, Jules. And I think that another myth, if we're moving through these, is that if somebody's on palliative care, they won't get treatment. And so I think that is sometimes a fear that people have, and that's why maybe they're hesitant to go on to service, whether it's palliative care or hospice care. So palliative care is given in addition to the prescribed treatment. Is that right, Jules? Is that how you would explain it?
Yes. And I would even say that most medical institutions, whether it's an office setting or a hospital setting, have palliative care teams associated with their providers, so that they can have an entire focus on the palliative care aspect of it, right? Maybe the doctor is still, your oncologist may still be, writing out their treatment plan and deciding on what their next steps are going to be for curative measures. And at the same time, they're collaborating with the palliative care provider so that they can make sure they keep in the forefront any symptoms that are really impacting someone's quality of life, to try to assist with really easing those symptoms while they go through the treatment. A very basic one would just be if someone is on chemo and radiation and they are having nausea, vomiting related to medications, an antiemetic medication or an anti-nausea medication is palliative care. It's a very simple way to understand that just treating the nausea related to the med that you're taking to cure the illness is palliative care. So they have to work together. That's the whole point, is that they go together.
Thank you for that example. I think that really helps clarify. And then I'm sure people are thinking, well, okay, then what about hospice care? If somebody goes on to hospice care, does that mean that they give up their treatment of whatever they might be receiving? And I've also heard families say, well, will my loved ones stop all of their medications when they go on to hospice? So can you give some insights on that?
Yeah. The way hospice works, and kind of the way that someone, when you meet with a family, I think one of these slides, we're going to talk about hospice philosophy, but at its like basic element, it's really that if you were to stop all medications at this point, right, or you were to stop treatment and the disease took its natural progress, is it expected that someone would not live beyond 6 months? Mm-hmm. That's the idea of like, is someone ready for hospice? When someone chooses hospice, it means that they are no longer trying to pursue curative measures for their illness, and instead are only choosing comfort measures. In reality, like, words are great, right? But it's also, they're very gray. So in reality, what does that look like? Because then you have that family who comes to you and says, does my mom have to stop all of her medications? And the answer is yes and no, right? There are some medications or some treatments that a hospice company will not feel comfortable bringing someone onto hospice services if they're still taking those medications. But if someone is maybe taking their blood pressure medication and they are taking, what's another common one? Let's see. Like statin medications for to reduce the plaques in arteries. Sometimes we don't say, oh, we're going to stop all your medications right now. It could be helpful for a family member to hear, like, no, they can still take their medications. They can still take their regular routine of life. And eventually, if someone doesn't want to take their medications anymore, we would take those things away, right? Mm-hmm. In other times, if someone is taking a blood pressure medication, but now they're in bed all the time and their energy is already low, we don't want to give them their blood pressure medication anymore because they might not need it anymore. It could be making them feel more sick than helping them. So there's a little bit of a dance that happens when someone goes on to services, barring any of those major situations. So what's an example? An example is probably, and I've even seen this be a little bit gray, is feeding tubes. If someone's on a feeding tube, oftentimes hospices are looking for a feeding tube to be discontinued or to not be in use in order for them to come onto services. But sometimes we've taken people on to service with a plan to stop their feeding tube in a certain amount of time, right? Sometimes that's something that we would do, but it's all very gray, and it's all kind of up for negotiation for whatever's right for a patient and their family, if that makes sense.
Yeah, I think that's very helpful to understand, and I think that that's why it can sometimes be helpful to make sure that you meet in person, you talk with the hospice provider, and perhaps even talk to a couple, just to see, the difference between a few different providers. That might make a family member feel comfortable hearing, maybe from two different providers, their plans of care that they would propose for the individual. So very helpful. Okay, we have one last myth, that hospice is only for the dying person, which it actually is a family-centered concept of care. And so hospice, I think, again, one of the beautiful elements of it is they do focus on the grieving family in addition to the dying patient. And so they often have, bereavement type services, clergy, social workers. So they have a number of people involved, a number of providers involved to help support the whole family unit, which I think is so beautiful. Definitely a benefit to hospice. And I hear a lot of families talk about how they were so surprised at this element of hospice, and for that reason, they wish they would have gone on to hospice sooner. So, Jules, any experience that you've had, or any other comments or stories you'd want to share on that last myth?
Yeah, I think that's really true. That people sometimes didn't realize all that they would get from hospice. and wish that they would have had those resources sooner, which is something we hear all the time. The bereavement aspect of it is big. I remember the hospice that I worked for, they committed to 12 months of outreach to get a family through all of the big firsts. The first holidays, the first birthdays, and then the anniversary of death, those kind of things. For the first year, having a resource that does some outreach just to kind of check in. And it's just nice to get a letter sometimes that says, hey, we remember you, and we know that this is the first time you're going through your dad's birthday. So that's a really beautiful offering that's there. But even before death occurs, sometimes our social workers, we think the social worker is there just to, do collaboration and maybe coordinate respite care and things like that. But sometimes sitting at the coffee table and just talking to someone to kind of be able to vent out what it's like to go through the loss of your loved one, that is a really important thing that we offer. Same with a volunteer, right? Maybe a volunteer can go to someone's house and sit with their person who maybe is bedbound at this point so that you can go take a shower, right? Those things are really, really important. And while we are there to care for the patient, the family ends up receiving a lot of benefits because of that.
That's awesome. Again, like we've said it a couple times, families so often say, I wish I would have used it sooner, because they don't realize all the benefits. So another takeaway from this webinar, hopefully, is that we can encourage families to be more open to the idea of hospice, palliative care, end-of-life care and support, so that people can get this service, which for many people is at no cost. And so I'll let you now, Jules, kind of take it from here and dive deeper into the various types of care and support at end of life, and then I'll join you back towards the end for some Q&A.
Cool. Thanks, Lakeland. Hello, team. I know you've heard from me a little bit already, but I'll give you just a little bit of background on me. My name is Jules, and I am a registered nurse. I currently work with Honor Home Care on their workforce development team, but prior to that, I worked in a hospital setting, doing progressive care, float pool type work, and eventually moved into hospice care. And sometimes when people ask me what I do for work and I tell them, they think that is very depressing. And I always try to remember that, working in the hospital and watching us dump all of our resources into trying to save someone, only for them to, be stuck in a bed and not be able to communicate with their loved ones and watch the deterioration in this way, is quite different than being able to go to someone's home and watch them choose what they want for themselves and make choices for what their care is going to look like in the future. It's quite a contrast to each other to see that you could choose a different way for end of life versus just being in a hospital setting. So that transition was really eye-opening for me. And I got into hospice because I had a nurse friend who had left the hospital and was doing hospice nursing, and said that it was the most rewarding work that they've ever done. And I trusted them, and to hear them say that, I thought maybe that's something I could do. And it has been very rewarding. So that's kind of my background on how I got into this field. And yeah, let's talk a little bit about what hospice offers, what it looks like, and then we can dive into some questions. So we talked a lot about palliative care already, so also referred to as comfort care. You've heard me say that it's a lot of symptom relief and symptom management, which is true. It's an approach to the treatment of patients with a serious or life-threatening illness, specialized to help manage and soothe their symptoms. And the goal is really just relief. It's relief from the symptoms, pain, and stress of the illness, and hope to improve their quality of life. Palliative care does not mean that someone is going to be on hospice or that they have to be on hospice. It's just a form of symptom relief. I even say we all engage in palliative care sometimes when we are really dehydrated, and instead of drinking water, we take ibuprofen, right? We are using a medicine to help cure a symptom we're having, when probably if we just drank water, it would solve the actual issue. Yeah, it's provided by a team of specialists, and I think I spoke about this before. Most hospital systems have palliative care programs that are instrumental in many things. It's instrumental in someone's experience being in the hospital, of course, but also they help bridge the gap often to the next level of care that someone might need. Maybe it's home health care, or maybe it's hospice care. But palliative care providers are a huge part of the like continuity of care within a health system, and especially important in trying to get someone home when their primary goal is to go back home. I worked with a lot of palliative care providers in the hospital system, and sometimes they are the ones that can have the hardest conversations. Physicians in the hospital that are, oncology docs or infectious disease docs, folks that are working in the hospital, sometimes they don't have the best bedside manner is not even the right word, but like language for talking about all of these hard things and hard decisions. And when we can lean a little bit more on the palliative care folks who really do have expertise in that, it makes for a better patient and family experience. So I can't say enough about how important palliative care is, and how those programs can really like make or break someone's experience and the coordination they need to get back home. Okay, I'm going to go to the next slide. Okay, so we're going to talk a little bit about a hospice overview and hospice philosophy of care. So what we mentioned before about philosophy of care is really that you are someone or and their family, but usually it really has to be patient-centered, is choosing comfort over cure, right? That is the major philosophy of care here. They no longer want to pursue curative measures, and they are ready to focus purely on comfort measures. Whereas palliative care, you're still accessing curative measures as well. Focuses on the pain, symptoms, and stress of serious illness during the terminal phase, and it can occur in a variety of settings, like we talked about before. So that general inpatient care, that happens sometimes, very rarely, either in a hospital setting or in an inpatient hospice facility. And that is really when you need someone or your health team to be hands-on with managing the symptoms you're having, because they're not able to be managed at home. That means that you probably have some sort of IV in, something that is not easily done in a home setting to help manage those symptoms. But a majority of hospice care is delivered in the home, whether it's in a private personal home or if it's in a memory care facility or an assisted living facility. Most of hospice is happening in someone's home. The thing to remember is that hospice care does not mean that someone is going to be with you 24/7 from the hospice provider. The nurse is not going to be there 24/7. In very rare cases, there's something called crisis care, where a nurse will kind of sit bedside for you for an extended amount of time to help manage symptoms with medications, to kind of prevent them from having to leave the home or to go into a facility. But oftentimes the nurse is just making one visit a week, maybe 2 visits a week, and those visits will then increase as someone declines more and more. Those visits usually consist of really just checking in to see how things are going, making sure that medications are stocked, doing patient education and family education on medication administration. And then if there's any other like health related things that you need the nurse to be doing, like wound care, usually we'll provide some wound care training and education to the family so they can take on that kind of thing. But the main takeaway is that hospice does not mean that a nurse is going to be with you 24/7, which is a common myth that I thought was true before I even got into hospice. So I like to mention that. Like we said before, majority of hospice care is delivered in the home. Over half of those folks, though, are enrolled in hospice for 30 days or less, which is really a staggering number, considering that the way that we would certify someone to be on hospice is that they have to be expected that if the disease would take its natural course, they'd have 6 months or less to live. So if folks are only on hospice for 30 days or less, there's a lot of time there that they probably could have been accessing benefit, and they haven't been. So it's just something for us to all keep in mind, especially for the folks that are on this call. You may be in a hospital setting or in a setting where you're talking to family members, and really trying to shift that mindset of what hospice is and what we provide. Hospice, I know for a lot of people, they think it lasts like a week, days to a week. That's always what I've heard. My family always believed that. And that's just not the case. There's so many benefits of hospice other than just those last final days. So something just to kind of think about. Okay, a little bit more about hospice here. It is provided by an interdisciplinary team, but often the primary support for someone on hospice is the family or the primary caregiver in that home. That's usually the person who's providing most of the tasks that someone would need at home. But there is an interdisciplinary team that is kind of working behind the scenes and also visiting in the home. And we're going to talk a little bit about, I think we have like a nice image of a circle here. Yes, okay. I really like this image. I'm going to start actually with the physician. I like to start from the top and then kind of move our way down. So there is always a hospice physician. The hospice physician is the doctor who needs to certify that someone has 6 months or less to live if the disease took its natural course. And something also to remember for folks on the call is that you need 2 doctors to certify this. So physicians in a hospice company, that's the first person that you need. And then the second person you need is the referring doctor, the doctor who also agrees that this person has 6 months or less to live. So there needs to be certified by 2 doctors. It's not like it's only the hospice doctor that's certifying someone is appropriate for hospice. So it's an important thing to remember. Also, this is no shade to the doctors, the physicians that work for hospices, but probably you'll never see this person. Family members usually never see the physician that works for the hospice company. They are working in the background to collaborate with the rest of the team. The people that you will see sometimes is, and they're not on this circle, but I like to mention it here, is a nurse practitioner. Usually a nurse practitioner works on the hospice team, and those are folks that you will have a face-to-face encounter with, or a patient and their family would have a face-to-face encounter with. They would be out there every 90 days to do that face-to-face encounter, and that is someone that you would see, but the physician you probably would not see. The nurse is, like I said, is someone that you are going to see. They're going to be the nurse at admission you'll meet, and then you may have a regular ongoing nurse, not the same nurse as the admission nurse. And like I said before, that frequency really depends on the needs of the patient. Generally, they're there once or twice a week, and then those visits will increase as somebody declines. Another thing to remember here is that the nurse always has access to the physician. So the nurse will always have 24/7 access to that physician. If they need a new order or something, and you need to talk about a symptom that's happening or a situation, they always have access to that physician. So it's an important thing to remember. Then we also have social workers, and the social workers are oftentimes accompanying the nurse at that first information session or sometimes even at that admission. And they will talk a little bit about what hospice offers and what sort of coordination somebody might need. They're very useful in the coordination out of a hospital setting into a home setting. They're also really helpful in navigating all those legal documents that Lakeland was talking about before with the advanced directives. And that kind of like out of hospital DNR stuff is very helpful for the social worker to be navigating. And they can always answer questions for you. They're also very useful in being able to accommodate for respite care. So say a family member needs some time or they have a vacation planned or something that they can't change planned. Sometimes they can help navigate respite care, which I think is something we're going to talk about a little later on. The chaplain, yeah, most companies, well, all companies offer chaplains. And what's important here is that chaplains are generally non-denominational when they work for a hospice company. And the way that we would say it is like, they're just chameleons, right? They go in there and they are just present to meet the needs of the family and the family's culture, right? They're not there to put any of their own beliefs onto a family or to a patient. They are just there to help foster whatever their beliefs are, and sometimes to just be a sounding board, to be present with someone and talk through their life review, which is something that they often do when they have their visits. So I guess what I'm trying to say is sometimes people can be a little bit turned off by the chaplain and will decline it right off the bat if they're not religious at all. But they are very much less religious and just more spiritual, which is a helpful thing to speak to when talking to families so that they don't feel so turned off if they don't feel like they're a religious home. Cool. Then we'll talk a little bit about the hospice staff. We have hospice aides that go in, and usually hospice aides go in 3 times a week, usually on a Monday, Wednesday, Friday cadence, but that can always get tweaked around to meet the needs of the patient or the family. And the hospice aide is the person who's really going to like help them get cleaned up. They'll do hygiene care, a bath, they'll change them. They'll make sure that the bed sheets are clean if they haven't been clean that day. They really can be present to help from when they first get on hospice, if someone is like walking and talking and moving, and then very instrumental when someone becomes bedbound or doesn't leave their bed anymore. So that hospice aide works really closely with the nurse too, because they are often the eyes and ears. They can see a lot more than the nurse does at first if the nurse is only going in once a week. So if there's a new wound, that hospice aide is going to see it, and they can let the nurse know that they can that there's a new wound and it needs to be assessed. So oftentimes they work in collaboration with each other really well. Then we also have hospice volunteers. So hospice volunteers are, in my experience, oftentimes folks who like are in the community, sometimes younger folks who are in school that have to get their hours done. And a lot of them are like in the medical field. So sometimes nursing students, sometimes med students, sometimes people who have lost a loved one with a hospice company that they just fell in love with and they want to give back in some way. Oftentimes they will become hospice volunteers. So they feel very connected to the work that's being done there. And it's a really great way for family members to sometimes get a bit of a break. And it's also nice for patients. You know, sometimes patients don't want to get stuck seeing the same people all the time. So when they have a volunteer come in, it's a fresh face, it's new blood, it's a new person for them to tell some stories to sometimes if they're still communicative. And it's a nice way for them to stay engaged and just, be engaged with their community and with a new person, and instead of just the same old routine. So it's really nice to have hospice volunteers. And then the other parts of the care team are a little bit different, right? So we have the family caregiver. A family caregiver is someone who's part of the family. And usually it's the primary caregiver, the person who's been navigating their care their whole time as they've been declining, right? Usually they're somebody who's bringing them to their appointments and learning from the doctors and hearing about all the changes that are happening. And they are people that are going to be providing medications. So at end of life, when somebody has declined to the point that they need comfort medications, family caregivers are usually the ones administering those medications. They are the ones that nurses teach how to do wound care and how to change them in bed and how to provide bed baths. Like, we would teach them how to do a lot of those things. So family caregivers are a major part of the care team, probably the number one part of the care team if you think about it, because they are there all the time. Then you also have professional home care, right? So if you need a little bit more help other than just what the hospice team can provide, then professional home care providers are a helpful tool to be using here. So they are folks, I think we're going to talk about this more too, but they're the folks that are going to assist with, activities of daily living, helping them bathe when the hospice staff is not there, when the hospice aide is not there, things like that. And it's a more useful tool than just having someone there for like an hour. Sometimes having someone there for 4-hour shifts, 6-hour shifts, as opposed to just the hour visit the nurse or the aide makes, is a really big help. So that's the hospice care team and all the key players that are part of the care team. And now we're going to talk a little bit more in depth about each one. So family caregivers, like we talked about before, these are the folks that are managing a lot of that care. They are the point of contact person. They're doing the medical and the nursing tasks. They're doing household tasks. They're doing the medication management, the personal care, all of that, which makes it a lot easier when we have someone hired in someone's home to take on some of that other stuff and to kind of lessen the burden a little bit. Respite care. Yeah, this is what I wanted to talk about. So respite care is time away from caregiving responsibilities. It's the opportunity to recharge or for your own self-care, for a family's own self-care. And it can be provided by the volunteers, by families or friends, or professionals in home. And oftentimes it can be provided by an inpatient facility. So sometimes skilled nursing facilities are an option that our social workers can utilize to have them go into a skilled nursing facility for a short amount of time. That way they can be away for the weekend and then they would move back home. So that is something that is possible. If on this call, y'all might say that this is not as easy as I'm making it sound, because I know this takes a lot of collaboration to do, but it is an option. And for folks who are taking care of a loved one in their home, being self-aware of when you really need a break is really key. And accessing these kind of tools is important. So don't feel like people should not feel shame about needing to access this kind of respite care. Okay, and then we're going to talk a little bit about home care. So this is provided by professionally trained aides, and it's meant to support the individual and their family. They assist with personal care, medication management, everyday tasks such as meal prep or housekeeping, just to kind of help lessen that burden. It's a really big deal to get a little bit of help, because folks who have been in this situation know that it can be quite taxing to be caring for someone in their home. And I have to say just that to be able to share some of this burden allows for a family or a family caregiver to be present enough for the specialness of this. I remember that I had someone when I was learning hospice who said to me that we spend 9 months preparing for a baby. We should be spending that same amount of time preparing for someone to leave this realm. And, that's not how it works here. Like Lakeland said, in the US, there's not a lot of emphasis on end of life the same way that there is preparing for a baby. But the journey is not that different. It's still quite an ethereal journey, if you will. So being able to lean on other folks and access help around this is so important, because there are very special moments that families can have with their loved ones as they're passing. It's a time where they sometimes share things that they may not have shared previously. They know that their time is becoming shorter, and they might want to talk more with their families and share special things. I think that in my experience of being a hospice nurse, I have seen many, many different situations, and some of them have been so beautiful and so right, and some of them have been really hard. And a lot of it falls on how on board is somebody with hospice philosophy. And sometimes it's not just the patient, right? Oftentimes the patients are ready. They are ready to leave this world. They are ready to stop having to fight in the way that they have been fighting against whatever their illness or diagnosis is. And their families sometimes are not on board with hospice philosophy. And that is the hardest part of this work. And I'm sure that folks who are on this call would agree that if you've had to navigate this, it's a very, very hard part of the work. My first death that I ever had was in a home, and it was a really large home. It was like a beautiful home in Austin, Texas, and this woman's mother was dying, and she was like in her 90s, and she was ready to go. She had said her goodbyes, told everyone that, you know, she was ready, and the family was able to get hospice care on board. And I remember I walked into that home and they had music playing in the house, and it was just this beautiful, beautiful music that was playing. And I walked into the room, and the family called in to say that they think that she had stopped breathing. And we had went in there to assess, and it was just the most peaceful, beautiful environment that I could ever imagine. And I remember thinking, man, if there's a way to go, if somebody has to go, this is the way to do it. And I remember above her bed, she had this beautiful painting, and I was talking to her daughter who was there, and I said, this painting is so beautiful. And she said, yeah, actually, my mom painted it. She recently asked me to take it out and to hang it in her room that she was in. And she said it was the most proud thing she'd ever been about something that she'd ever made. And it was just so beautiful. And it was a really dignified death. And at the end of the day, what we have to remember is that we are trying to provide dignity for someone who is leaving this world, and to provide love and support for the people that are losing their loved one. And there are all these fancy things that we talked about on this presentation, and things to learn and to know about that are important. And at the end of the day, the thing that I always say is that it's really just humans helping humans. And that was really what it looked like that day. And it was just really beautiful. And then, you know, on the flip side, you have situations where family members are trying to prolong someone's life as much as possible without really considering their quality of life or their dignity. And those are really hard things to be navigating. So utilizing all the tools that hospice has to offer, and all of the specialties within the team, so that not one person needs to know everything there is to know about death and dying, and really relying on the team as a whole, is so helpful in navigating these hard situations. Because a beautiful death, and one that is accepted, where someone has moved through all the stages, is quite easy to navigate and manage, right? The hardness of this work and of hospice is when not everyone is on the same page, and when there is so much grief and so much denial and so much pushing against, that it makes that death so much harder. And for the health professionals and professionals on this call, just give yourself a hug and a break, that like you are navigating all of these things all the time. And it's really hard. And it's also very, very valuable work. So I just kind of want to throw that out there. I think that we have one final quote here, which is really beautiful. It seems indeed important that we face death before we are in any real danger of dying, and reflect on our mortality before all our conscious and unconscious energy is directed to the struggle to survive. It is important to be prepared for death, very important. But if we start thinking about it only when we are terminally ill, our reflections will not give us the support we need. And I think it's just full circle around how Lakeland opened up this presentation. And at this time of year, you know, it's holiday time. I'm sure some people were spending time with their loved ones. It is a special time to be talking with our family members and with our parents and with other folks around this kind of stuff. Sometimes we don't spend as much time with our families as we grow older, and we don't have as much time together to talk about this. And it could be a good opportunity to bring some of the advanced directive conversations up, especially just at this holiday time. Okay, I'm going to pass over to Lakeland for a few minutes of any questions.
Awesome. Thanks so much, Jules. I think the information you shared so helpful. And I wanted to leave this resource slide up here. I know there have been a couple of questions that have come in around tools for conversations around end of life. And I would point you all to the 5 Wishes and the Conversation Project. Those are both great resources on, fostering this conversation and helping open up a dialogue. They also have some of the important documents, some templates or resources to point you towards as well. And there's so many great books around this topic of end of life. And some of my favorites that I've read are stories of hospice nurses. And there's a few of them listed there on the slide. And I know we're at time. There's a lot of questions we're not able to get to, but Victoria, if it's okay, I might just address 2 quick questions before we wrap up. Many people have asked, sometimes a person will be on hospice longer than 6 months. And so, Jules, I was wondering if you could just comment on, what if somebody reaches that 6-month period, can they requalify? Or sometimes I've even seen people go on and off hospice because the extra supports actually help them get a little better. So can you just address that quickly before we wrap up?
Yes. Yeah. No, there's no time limit on it. It's not like you'll get kicked off hospice at 6 months. There's a recertification process where a nurse would go in, do an assessment, bring it back to the medical team, and then the medical team and the doctor would have to recertify them for continuation of services. And also often we call it sometimes graduating off of hospice when someone's condition improves.
Off of hospice for some time because they no longer need care or services, and then we'll get back.
Thank you so much, Jules. Well, I think I'll turn it back over to you, Victoria. Thank you all so much for joining us on this topic. Again, wish we could have gotten to more of your questions, but I'll share this last slide. If you have any other questions, feel free to email me and I can do my best to get them answered. And thank you all so much for your time. Also, wishing you all a wonderful holiday season and Happy New Year. And we'll be posting our 2025 webinar schedule soon for the Home Instead webinar series for 2025. So be on the lookout for that.
Thank you. Thank you all for joining us today. I will consolidate these questions and see if we can do something with them because there were so many questions that came in and everybody was very engaged. So thank you all for that. And thank you for joining us today to explore this really important topic and the importance of hospice and end-of-life care. And we hope that this conversation has shed some light on how thoughtful planning and compassionate support can honor dignity and enhance quality of life during this stage. A special thank you to Home Instead for making this session possible. Don't forget to check out our webinars page for helpful guides and FAQs. There is a how to claim credit tab at the top of your screen. So if this is your first time claiming your certificate, check that out before you submit your application. If you have any questions, feel free to contact us at institute@asaging.org. And like I said, visit our website for upcoming webinars. Thank you again, Lakeland and Jules and everyone here today. We truly appreciate your participation and hope you have some happy holidays and Happy New Year. Thank you.